You're listening to National Health Executive's Finger on the Pulse podcast with me, your host, Saskia Hicking, here to guide you beyond the headlines with news, views and insider truths from across the healthcare sector. Hello and welcome back to another episode of NHE's Finger on the Pulse podcast. Today, I am joined by Dr Giles Yeo and Dr Stephanie Giorgio, and today we're going to be discussing some of the stigmas that exist around excessive weight and obesity. Now, that's not just in society in general, but also across the medical sector as well. I realise we probably have plenty to talk about in today's episode, so I'm going to start off with Giles. If you wouldn't mind just introducing yourself and letting us know a little bit about what you do and why you've got such an interest in this topic.
Oh yeah, so I'm a geneticist, so I study genes as indicated in the name. But I'm a geneticist that studies body weight, of which obesity just happens to sit on one end of the spectrum. So I'm interested in why people are small, medium, and large in this environment that we live in today.
And Stephanie, if you wouldn't mind just introducing yourself as well.
I am a GP and clearly see people who have a huge range of body weights, and became very interested in obesity about 6 years ago now, and realised that I was not taught anything about obesity at university. I left in 2000, and it's pretty much been a field of science that has grown since then, really.
And this might be quite a vast question to ask straight off, but Giles, why do we have such a problem with weight gain? Why do we find it so difficult to maintain or to lose our weight, and perhaps so easy to gain it?
It's a good question, actually, and the answer might in very many ways seem obvious, but we now know that by studying the genetics of body weight, we are almost by its very definition studying the genetics of how our brain influences our feeding behavior. So put simply, we now know of over 1,000 genes that influence our body weight, and the vast majority of them act A, within the brain, and B, influence our feeding behavior. So put simply, some people, because of their genetic makeup, find it far more difficult to say no to food than someone else for a myriad of different reasons. You find it more difficult to say no, you eat more, you gain weight. So simply that is the reason. Because of our biology, some of us are more driven towards food than others.
And Stephanie, I don't know whether you have anything to add to what Giles just said there, but perhaps any of the societal factors that play a part in this.
Absolutely, what Giles says is true. And I think what then adds on to that is the environment in which we live is different to the environment that we have lived in for millennia. And so the interaction of those people who are more driven towards food and get more reward from food is more difficult because we're in an environment full of food, and full of food that isn't particularly good for us as well. So it's incredibly difficult. And once somebody has gained a specific, we don't know yet exactly what sort of extra weight, but once someone has gained weight, their body will work to keep that weight on. And when they try and lose it, it will come back. So it's a really difficult mix, and not an easy one to manage at all.
And we say it's not easy to manage, but how big of a problem is obesity? Not only just for the NHS, but society as a whole.
I think it is a problem that is much bigger than the NHS. The reasons that people gain weight are as Giles and I have said, but it is linked very much with poverty. It is linked with deprivation, and it is not a problem that the NHS alone can fix. And at the moment, a lot of the NHS programmes are very focused at the individuals, and what a lot of the work that those of us involved in obesity do is to try and explain that this is very much a societal problem and we need a societal solution. And so the problem is significant. Of course, those with obesity are more at risk of certain conditions, but it should be treated like any other disease, and we need a solution that looks much wider. And we need two things. We need to try to help those who have a tendency towards obesity to prevent them gaining the weight in the first place. And that again is a societal issue. We need to pay people to be able to eat good food. We need them to have housing. We need them to have space. We need them to not be horribly stressed. And then we need to provide evidence-based treatments for those who already have obesity to help them lose the weight and keep the weight off as much as possible.
So we talk about some of the societal factors there, and physically what is needed to help those people through that time, whether that be services on the NHS or whether that be more of an understanding of what's going on in their body. But what are some of the stigmas that exist and that people that suffer with obesity have to endure every day?
Having overweight or obesity and moving through the world and living in the world in which we live is very difficult for people. The stigma that you mention is enormous. It starts really young. If you look at children's books and children's TV programs, characters who have overweight or obesity are often silly or lazy or greedy or the bully. And that goes on through books, movies, TV programs, all the way through. So people are constantly being bombarded with this message about people living with obesity. And that means that people are judged by other people. But it also means that people with obesity develop what we call an inner weight bias, a negative inner weight bias. So they themselves feel bad about themselves. They feel like they've failed. They feel like they can do anything in their lives except manage their weight. And it is a horrible, horrible feeling. And they will live with that very negative inner monologue all the time. And they will not access healthcare. They will feel they're not worthy of healthcare. And so the implications for mental health, as you can imagine, are significant if you're having constant negative messages bombarded at you. If you try and go to the gym and people take the mickey because you're bigger, you can't buy decent clothes to go to the gym. People look in your shopping trolley and go, should you really be eating that? People judge you everywhere you go, and it is a deeply unpleasant experience. So the relationship between mental illness, and obesity is a two-way process. And it is a really, really difficult one. And it's why any good treatments for obesity should really include psychological support as well.
And we're going to come back to that, Stephanie, because I think the mental health aspect is a huge part of this, isn't it? But Giles, I just want to bring you in here and talk more about the physical, the scientific reasons for why this is happening and why people get to the point of even experiencing this stigma. So what is happening inside our brain? How is our brain controlling our appetite behavior?
So I'll give you just a couple of examples, and there are many more, and they're not mutually exclusive. This is the critical thing. There's overlap, but just some simple examples. So our brain needs to know two pieces of information, two key pieces of information in which before it can regulate our food intake. So first, it needs to know how much fat we're carrying on our body, because how much fat we're carrying on our body is how long we'd last in the wild without any food. Or your food stopped today, how long would you live for? So that's long-term signals. And secondly, it needs to know how much you have just eaten and how much you are currently eating. So your short-term signals. The long-term signals come from your fat. The short-term signals come from your gut. So your brain then senses these long and short-term signals, and then influences your next interaction with a menu, a refrigerator, or a supermarket. Okay, so I tell you this because some of the genes influence these pathways. So for example, some of the genes influence the sensitivity your brain has for fat. So imagine if, say, I am carrying 20 kilos of fat on me, all right, but my brain only senses that I have 18 kilos of fat. So what it does is it's going 18, I thought I had 20. So it drives you to eat more to try and get you to 20, but you're already at 20. So what happens is you get larger. Equally, from a food intake perspective, just from eating, say you've had 1,000 calories for lunch, but your brain only senses 800 calories. You see where I'm going for this? It drives you to eat more, which is why two different people can be sat across from each other, eat exactly the same meal, and one feel full after the meal, and another says, "Ooh, I'm still peckish. I could still eat a bit more." So those are just two examples. I mean, there are a whole lot of other examples that one could have, but why people might eat more than someone else or feel hungrier than someone else.
And of course, Giles, this is your expertise. You know everything there is to know about weight, but are we missing something? And perhaps we need to understand a little bit more about weight and particularly excessive weight and weight gain and obesity? Is this something that if the general public knew more about it, then this stigma wouldn't exist?
I have to say that not only is the general public not know, but our healthcare professionals, the vast majority of healthcare professionals don't know this either. And so it is our duty, Stephanie's and my duty, to make sure we bang the drum, make sure we say, look, there are these pathways, there are reasons why folks find it more difficult to eat. I mean, the problem with food intake and feeling hungry is that, you only know what you feel. Whereas someone who's biologically programmed to eat less than feel full are going to say, well, but I only had one muffin. Why do you have to have two muffins? I don't understand. You just have to be like me. And that's because the skinny person doesn't know what the larger person feels like. And that is part of the problem. And that's fine. That's fine. They're not understanding it. And so I think we need to then make sure people understand that there's biology underlying how we feel and our feeding behavior.
Okay, so we talk about teaching here. How hard is it? How hard will this be to educate? Like you say, it's not about society in particular. What you're trying to do here and what yourself, Stephanie, and Giles want to do is inform health professionals a bit better about the trials and tribulations behind obesity.
I actually think it's not as hard as it could be. So all healthcare professionals continue their education. They all have to, we all have to learn new stuff all the time. There's new stuff in everything. What's been different about obesity medicine is that it's a new topic. The stuff that Giles does, people weren't doing years ago. It's brand new. There are hormones, there are chemical messengers, there are things that nobody will have heard of. And so I think it's really important that we start education programs so that healthcare professionals are not judged for not knowing it. It's not their fault they don't know it. They've never been taught it. But now that we do have this information, we need to get it out there. And so, I educate GPs. I educate other colleagues as well. That's part of my role. And what's lovely actually is when healthcare professionals do learn the science, they do learn the medicine, and they do learn how to have a really good consultation with patients with obesity. It's like a little light bulb comes on and they're really happy, because none of us like to do a bad job, but we like do something helpful, and that feels good. That's our job. I think it does. We know that stigma is unfortunately rife within the healthcare professionals as well. But once they learn the science, that disappears as well, because they get it. And so it's a win-win. And actually good targeted education that can be quite quick is happening, and it's happening more. And I think we're reaching a turning point at the moment, actually, that people are starting to understand. We've got a way to go, but I think we've reached a tipping point, which is amazing.
And like you rightly mentioned there, Stephanie, everything that Giles knows wasn't a thing X amount of years ago. It's relatively new, and it's very specialist in some senses as well, isn't it?
No.
But Giles, what do you think, if you had to give a condensed nugget of information that you think all healthcare professionals should know about obesity or about weight, what would it be?
So, I'm trying to start them young, but I only teach at one institution. I teach in Cambridge, and I am the first lecturer that the entire intake of medics in Cambridge sees. Okay, so I teach preclinical. I'm not a clinician. I just want to be clear, but I teach them biochemistry, and I teach them about diabetes, and then I teach them about obesity. So look, they may forget by they're 18 years old, they're embryos, right? So by the time they actually become medics, maybe they'll forget who the bald Chinese guy was speaking to them. But I try. So that's the first thing. But if I were to sort of distill down what I think medical professionals should know in its simplest form, they don't have to understand the minutiae of the details. That's not the point. I think the point is first of all that there is a huge distinction between saying that obesity is an issue, okay, and saying that we shouldn't blame the people suffering from them. So that's the first thing. So you got to go in and say, there is a problem here. I'm going to try and help you, Mrs. Smith, solve the problem. And by not blaming them, I think, therefore, you remove the blame from the thing. And that's all people are looking for. This is, I've got a problem, doctor. Can you help me? That's the first thing. Then the second thing is that one size doesn't fit all. So now you have to not only think about the biology, which is what the doctor is trained to do, obviously, but also think about the lifestyle of the patient in front of you, rich, poor, parent, old, commuter, whatever. Okay, because it's useless to try and force someone to do things if it doesn't suit their lifestyle. The only way they will be able to do it is if it suits their lifestyle. So I think those two things, if you can get that in there, then you can start to move in and talk about what drug, what approach, what intervention you might actually have. But if you begin from a position of empathy and you begin from a position of, wait, I need to know about you before I can help you, I think those are two very helpful things.
So picking up there on needing to know the knowledge before you can help somebody, have we got a lack of help there? Is there a gap that is causing, because we know, there's rising statistics for obesity within the country, well, across the UK and probably across the world. But is there a gap here in the UK that we're not filling in terms of services?
Yeah, so I think there's two issues really. One is there's a big difference between somebody who has a kilo or 2 or 3 to lose and somebody who has significant established obesity. And at the moment, the system is not set up to really differentiate very well between that. People have to go to tier 2 services, then to tier 3 services, and then possibly to tier 4. And we need to be able as GPs to have, first of all, to have services we can refer to. 50% of GPs don't have services they can refer people to. So we need the services. And then once people get into the specialist obesity services, so tier 3 services, they're treated as individuals within that. There's a multidisciplinary team and there is time. It's before that, or when people don't have access, that it's really difficult. So if I have somebody who, say, weighs 30 stone and somebody who weighs, 12 stone and perhaps should weigh 11, I have the option to send both of those people to a 12-week walking group. That's all I might have. Now, it's not a bad thing for either of those people to walk, but the person who weighs 30 stone might struggle to walk. It might hurt to walk. They may never have been able to. They might be at the back and they might feel bad because they don't want to be the person at the back and they feel humiliated in that scenario. So the system is not set up to tailor for individual needs. And I think that until we take away individual blame and make a much better holistic approach to assessing all patients who have obesity and giving them treatments that they need, until we get to that, we're not really going to tackle the problem in a way that is evidence-based for individuals. And the other thing is, I work in an area of really high deprivation. So there are people who live in, for example, houses of multiple occupancy. They don't have a fridge. They don't have a cooker. They have a microwave. I can't tell them to make healthy stews and soups. They don't have the facilities, and they have kids, so they may be living on fast food. So until we manage that as well, we're failing people living with obesity.
So I feel like we've kind of covered both here. We've covered the stigma and we've covered the problem itself and how the problem arises with weight. But where does the problem lie? Is it with the stigma we've created, or is it with rising obesity levels? Where do we place our focus and where do we look to improve this?
You start, Giles.
Okay, I think it's both. I think there is a problem. There's a rising issue with obesity that is environmentally driven. Okay, so that's the first thing, because these genes that make us susceptible have always been there. So it's the environment that is unmasking the situation. So the first thing we got to do is we got to try and think about the environment, and therefore think about how people interact with the environment. But the stigma is preventing the right resources being deployed and the resources being deployed in the right place. Because and you might say, well, what does that mean? So if people think there is a broadly one-size-fits-all solution, then you're going to put together a different strategy than something which requires you to look at the individual patient that is actually sat in front of you. And so we need to push that there are different, and if you don't believe there's a biological reason for why people are heavier than others, then you're also not going to put the resources in the right place. So I think one definitely feeds into the other, and they're not mutually exclusive in any way, shape, or form.
I think Giles has nailed it there. I think the two interact completely. And I think that the history of why there is so much stigma on obesity is completely fascinating. And